right. I'm going to give just brief descriptions of our speakers today, and then during the presentation, each will kind of give a fuller picture of the facilities that they work in, which will provide perspective on their policies and procedures when it comes to securing mobile devices. So the moderator, and this is an hour-long session, so we have a little extra time for questions at the end, and I think this is going to be a pretty interesting topic. The moderator of today is Chuck Parker. He's the Executive Director of Continua Health Alliance. Chuck is also, the Alliance is a member-driven international organization focused on developing an ecosystem of plug-and-play, interoperable, personal connected health devices. And our speakers are Ralph Johnson. Ralph is the CIO of Franklin Community Health Network in Farmington, Maine. Ralph has worked in the healthcare information technology field for 28 years, most of that time in leadership positions in Maine hospitals. Ralph also serves on the New England HIMSS board as president-elect. We have Jason Zellmer. Jason is the Executive Director of Technology Risk Management for Kaiser Permanente. Jason serves as Executive Director of Technology Risk Management for Kaiser, which serves more than 9 million people from 35 hospitals and 431 medical office buildings in 9 states and the District of Columbia. Kirk Larson is the Vice President and Chief Information Officer of Children's Hospital of Central California. He took over that position in November of 2010. He has held a variety of healthcare positions over the years, including senior management consultant, healthcare consulting, and senior manager service and support for Cerner Corporation. So with that, I'll let Chuck take over.
Hi, thank you very much for joining us today, and hopefully we get some information out to you. But one of the things I do want to make sure of, and you've seen it so far in the sessions, is that we want to make this a very interactive session. So we're going to hear a little bit from the panelists on what we're going to be talking about, but I want to encourage you to come to the microphones. If you don't, I've got questions I can fill in for these guys, but I want to make sure that you're getting the information that you need as well. So please get your questions ready and once you hear the speakers. So I just want to say thank you very much for the panelists here. I'm Chuck Parker, Executive Director of the Continua Alliance. We represent an organization that is working towards the standards for interoperability for personal care devices. So this is sort of we're going to talk a little bit about that later in the panel discussion, but primarily what we're after today is talking a little bit more about the BYOD strategy. What happens when you bring your own device to work, and how do we actually ensure that we have the right security, risk management, and profiling activities to manage those device architectures? In some cases, we have organizations that have simply said, no, we're not going to bring those. But there are other organizations who've developed very advanced processes and policies, as well as deploying software on these devices to ensure that they can actually deploy them inside their facilities, as well as outside the facilities, and start to carry them forward. In the future, we'll actually start to see these devices even move further than that. We'll see them move into the home where the individual begins to use them and pass information back to the system as well. So I think that's an area of interest as we begin to talk a little bit further about how this BYOD strategy rolls out not only to our facilities, our employees, but also to our customers, perhaps as patients as well. With that first said, though, I'll turn it over to the panelists and let them talk a little bit more about their facilities, and we'll start this discussion off. So I think at this point we'll have Ralph start. So.
Sure. As I was introduced, I'm the Chief Information Officer at Franklin Community Health Network in Farmington, Maine. Franklin County is about 2.5 times the size of Rhode Island, but it has a population of 40,000 people. So it's a very rural community in Maine. It's also the second poorest county in the state. So we have a very high Medicaid, Medicare population, heavily dependent on a government payer mix, which presents a lot of financial challenges for the hospital. In fact, as an aside, last year, meaningful use funds actually were the margin for the hospital for the year. So we work in a pretty tight environment financially, so it sort of dictates what our policies are. I remember 6.5 years ago, I came to Franklin to interview for this position. And I got there a little early, and I got in the parking lot, and I took my BlackBerry out because I was working in Portland, Maine at the time. And I thought, well, I'll check my email one last time before I go in. And I looked, and it said no signal. And I said, yes, I want to work here. So So for quite a while, I didn't have to worry about a BYOD policy. Even when the iPhones first came out, and of course AT&T was the only vendor for the cell network, it was not available in our area. So I had doctors who would actually drive to Portland to buy an iPhone in order to keep their minutes up so that they could actually keep it active. So it wasn't really an issue for us. It's only been the last couple of years that we've really had to face up to it. So, you know, our policy pretty much is we do allow BYOD. Number one, I can't afford to buy all providers the devices. But it's pretty much limited to their email and calendaring, and we put some restrictions on them. They have to allow us to remote wipe. They have to allow the encryption on the devices. And I guess I'll leave it at that for now. We'll take the next questions.
Sure. So just want to move on down one.
We started in the middle, so which way do you want to go?
Either way, Kirk is fine.
All right.
As introduced, I am the Vice President and Chief Information Officer of Children's Hospital Central California. Children's Hospital, we are a facility with 348 beds, with a medical staff of 525 physicians practicing in over 40 subspecialties. Our size makes us one of the 10 largest pediatric hospitals in the country, and in fact, the busiest children's hospital in the state of California. Similarly, we too have a very high what we call Medi-Cal or Medicaid rate. So that's also relevant to us. We service an area, believe it or not, of 45,000 square miles throughout California's Central Valley. And within that area is about 1.3 million kids. So at Children's Hospital, we also allow BYOD. Our bring your own device strategy really has its origins in the summer of 2011, which for us was a very transformational year. That was the year that we went live with our advanced clinical system, or the advanced clinical modules of Meditech. So we introduced nursing documentation, CPOE and such. And at that time, we were really wrestling with kind of three things simultaneously. One was the securing of data on this new proliferation of just the sheer number of devices, which was the second consideration, and then also how best to utilize our resources, whether they be the physical devices themselves or the folks that support those. So what we ended up doing for our advanced clinicals was introducing a virtual desktop environment. And we sort of unknowingly were planting the seeds for what would ultimately be our BYOD strategy, because ultimately how we supply BYOD is by any device that can download a client, which is virtually any device, can then access the user's virtual desktop environment on the back end. So the beauty of that from a security perspective is at no time is there physical data on the device, because it's all virtual on the back end. So if the device were to become disconnected, lost, stolen, as soon as it breaks the connection to the virtual desktop, the data accessibility is no longer available. So we offer that. We presently have that. The technology exists for anyone who is clinical, could access their virtual desktop through their own device. However, our organization has decided from a policy perspective at this time only to offer that accessibility to physicians. So we are presently enabling physicians to bring their own device. And as you can imagine, physicians are very clever, and they do in fact bring any device that you can think of. So I'll leave my comments at that as well.
All right, Jason.
All right, thank you. So as we previously mentioned, I work for Kaiser Permanente. We service about 9 million members, so we're probably on the larger side. The kind of the unique thing I think about Kaiser is it is an integrated health system, so we're both the payer and the provider, which puts us in the situation of dealing with both the insurance side of things as well as the care delivery side. I guess I'll start with the punchline. We do not allow personal devices, but I think the process we went through to get to that decision is something you can do regardless of what path you're going on. So when we went down this, what we first started to do is we really took a close look initially at use cases and said, what is it that people really want to do with these devices? So we viewed it as a data issue. Where's the data going? How's it going to get used? And regardless of whether or not it's a phone or a tablet or a laptop, we want to make sure that that data is secure. I think a couple of people mentioned here already some of the key use cases. Email and calendar is kind of the dipping your toe in the water piece of it, right? Where do you go? But in a healthcare environment, even that can be quite dangerous because I'm sure none of your companies send things around in Excel spreadsheets via attachments, but unfortunately we did. Then people started talking about network access and file shares and how can we actually get some of these documents to go back and forth between these devices. And then lastly, we are an Epic shop and they have an iPhone, iPad application, and of course they wanted to use that as well. So then we started to look at the realm of applications. And then for Kaiser, there's a whole another segment of this, which was what are we going to do in our customer-facing environment? We do actually have an iPhone and an Android app where people can log on and see their medical record, their test results, et cetera, and a mobile website that does the same. So once we kind of had that all laid out, we started to really take a look at controls and what's out there, where is that data flowing, and how can we control that? And really, we just saw this as something very similar to the laptop. And it was kind of interesting about the time I was preparing for this, NYU Poly and AT&T had come out with a survey that said, right now 90% of companies are allowing some access via mobile devices to their, whether it's email, calendar, network, et cetera, and only 32% of them are deploying controls to that. Or you compare that to 82% of companies will apply controls to laptops. And it just kind of struck me because if you look at it as it's the data and what are we doing to protect the data, why in one case would almost over 80% of people protect it, but in another case, a third of people are protecting it. So for us, as we started to break that down, obviously the mobile device management space is something that's growing quite a bit. There's a lot of great options there. Virtualization is another option we looked at. But really what we came down to is these aren't controls that we had in place at the time. And so our policy right now is to focus on delivering KP devices that have the controls on them, and then look at how we can expand that infrastructure out to support bring your own device in the future.
All right, thank you. So here again, I want to encourage you to, if you have questions, go ahead and stand up and come to one of the mics. We'll certainly engage and let the panelists help explain some of the things that they're doing. Just over here.
This may be geared toward the large organizations, but suffice it to say, bring your own device is more than that. It's bring your own network. And I'm not hearing what the larger facilities can do in the aggregate to broker a deal with the carriers to ameliorate the fear of what's really going on here. You rightly mentioned it's where the data is going, right? Mm-hmm. In the Adventist example, it was looking at the links in the data flow as the weak points or the low-hanging fruit to assess risk. What movements do you see the large providers doing to build a new relationship with the carriers, AT&T, Verizon, what have you? There's a huge opportunity there to join at the hip, if you will, and to figure that out. A smaller organization seems to be more willing to virtualize. It may be more cost effective. That price is going down. So a large organization can't say, I can't afford not to virtualize. So that argument's not really going anywhere. So, what are we doing with the bring your own network?
Excellent point. And from the KP perspective, that's something we looked at is just as it's traveling across those networks, how do you do that? I don't really have an answer for you right now, to be honest. It's one of the reasons we don't allow personal devices.
Just to answer your question from our perspective, we're starting to see that, with a couple of the large carriers taking on that risk. So Verizon just made some announcements here recently over the last month that they're willing to take on that risk for you and develop that, not only provide you the secure network, but also the identity management that goes behind that, as well as ensuring and meeting all the business associate agreements that you may have to manage as well. So We are seeing some of the telcos start to take on that risk and assumption that this is going to be a business model that they want to get into. So it is something it's starting to take place now. Yes.
Good morning. I'm in the process of crafting my own BYOD policy for the group of clinics that I'm here to represent. In looking at the policy, I realize that tablets and smartphones are converging more and more closely with laptops. You mentioned laptops, and I assume that a BYOD laptop is strictly against policy, while BYOD smartphone and tablet is. Where do you draw that line? You know, how do you define what is a laptop? You know, I know I can point at a laptop and say that's a laptop, but how do you say in a policy which one is which?
In our environment, we actually don't need to make that distinction because we allow the devices to attach to the guest network, which we secure from the public point of view. And that way, if it's a provider who's bringing in their own laptop, that's what they have to actually use is connect to our guest network and then use our remote access device. So they don't actually go directly to our network when they bring their own device in. That's sort of, it's a poor man's way of accomplishing it, but we secure that guest network against all the things the kids will do on the pediatric unit and the teenagers who come into the lobby. We're as secure against our providers with that method.
And similarly for us, really our litmus test is if your device can download the client to view, that's something that you can use for BYOD. So really any device, whether it be laptop, tablet, smartphone, if you can download that client, you can use BYOD. Now I will say that kind of harking back to my opening comments that physicians are clever, and I think that all of the end users will be as well. Something that we discovered was, again, taken in its literal sense, if your device can download this client, you can access BYOD. Well, some folks started bringing iMacs. So people brought in, which is literally a desktop, but it's wireless, and people were able to download the client and use that over the BYOD network. Per policy, it's acceptable. I don't necessarily have a huge issue with that, although we did identify, and I would suggest this to you as well as you're thinking about policy development. We did specifically call out in there that your primary device is what is supplied by the hospital, so that if that device were to go down, we don't want users to come in and say, okay, take my PC away because I have my iMac from home which sits on my desk now. We're not prepared to support that type of environment, and we had to specifically call out that your PC, which we provide you, is your primary device. Furthermore, with the BYOD, the support piece, we've also made the delineation that what we support is the connectivity. We do not support the device itself. So in other words, if you bring in your iPad from home, we will help you install the client and ensure that it connects to our network. We will not help you find your family pictures. We will not help you fire up the whatever movie you happen to have downloaded from God knows where. But it's an important distinction that we're not supporting the device, we're supporting the connectivity to that device.
Yes.
Healthcare has a huge set of the legacy applications and infrastructure which is built, for the past 30 to 40 years, right? A lot of, the application or infrastructure, they are not mobile device friendly. I'd like to have a question regarding what kind of, the typical challenges or special efforts you've already taken to kind of, modernize the legacy infrastructure applications to make it more useful for the mobile devices.
I can start from our perspective. That was actually, we have a whole set of infrastructure that we developed specifically for delivering to mobile, so that it's on the network, it's in the data center, it can talk to those systems, but we literally end up displaying it through mobile optimized websites or either our Android or iPhone apps.
Mine's much simpler. I don't. Yeah, we have one legacy app that will not run on these devices, except for if they bring in their own laptops or other devices. And then again, you have to come in through our remote access, which is a Citrix-based secure solution. So I'm not adapting them, and I'm not looking to the vendor to adapt them for me right now. I have a small medical staff. The total medical staff at my hospital is less than 100. They're very satisfied with what they have right now. I meet their needs in other ways, so it's not a high demand for me, as opposed to somebody in a much larger organization with a bigger constituency.
And we're in a similar situation where, and I agree with the question that a lot of applications are not designed, at least in their present state, for say a tablet. In our experience, when we were rolling out our advanced clinicals, there was a lot of clamor for tablets and iPads and the Android equivalent, but at least in the current state, for a lot of the HCIS systems, those devices are really good for viewing data, not necessarily for entering data. So what we found was people would try those devices and actually return them if they were in areas that were heavy data entry areas. In contrast, for some of our clinicians, some areas, for example, maybe a dietitian who does more viewing of data, a device like that is more appropriate. But back to the initial question, we too are not, we're not doing that development in-house and are looking to the vendors to do that development. And there's really a varying degree of progress there. Some are kind of ahead of the curve and are coming up with, say, tablet-specific applications, and some are behind the curve, and I think in that case, we need to wait for the vendors to catch up.
And just a quick follow-up on that question from my perspective as well. What are you seeing here as the percentages, if you will, sort of iOS versus Android? Or versus an other in this case?
Yeah, so for us, we don't have Android as a supported platform. That was just a security decision.
Probably mixed in my environment, but again, it's primarily email and calendaring, so as long as it'll support our requirements, it's fine.
And in our environment, believe it or not, in the smartphone space, we actually have more Androids than iPhones. In the tablet space, iPad is probably the predominant device, but we are seeing an increase in Android-based operating systems.
Okay. Question over here? Yes.
Thank you. In our environment, we have pretty well dialed in, I think, access to clinical systems through virtualization technology, get people to our EMR and to be able to put in orders and that sort of thing. The bigger challenge that we're having, now that we've sort of solved that one, is really around the Dropbox or Dropbox-like services, and I wonder through what combination of policy or technology solutions you folks are addressing people's desire to take documents and reference materials and other things back and forth between work environment and personal device environment. Thank you.
It's a great question, actually. It's something we deal with quite a bit. So we block Dropbox, Evernote, all of those, through the network. We haven't found, I don't think, a equivalent to really give them. We have some internal collaboration things, SharePoint and FTP and things like that, but file shares, but they're really not as easy to use, so it's something we're looking at right now, but we haven't come up with a good solution yet.
Neither have we. I would say, the remote access portal that we use for our providers, one of the options they have is they can do remote control of their desktop, so they can actually go back and gather their documents, work on their documents by emulating their desktop, and that's how they'd accommodate that.
And we're in a fairly similar situation as well, and I think this kind of goes back to the earlier talk this morning. There is a point at which kind of technology flows into policy, and there's certainly some things that, such as Dropbox and other things that you conceivably could do, but you need to have policy in place that even though someone could do it, It's similar to people on patient floors. Everyone has a cell phone with a camera. There's no way you can possibly block everyone from accidentally taking a picture. That's a situation where it's more policy versus technology, and I think at least in our case, and it sounds like my fellow panelists as well, we're still kind of developing in that space and relying more so on the policy versus the technology.
It's over here.
I'm curious, in addition, pardon me, getting over a cold. I'm curious, in addition to medical records, what type of a risk you see and what policies you have around communications and messaging, both providers within your institutions and possibly with specialists and other folks outside your institutions?
That's a great question, I think, from my standpoint, because there's other things, one of the things we're dealing with right now is text messaging, for example, and so from a policy standpoint, we do not allow any PHI to be sent unsecurely or not encrypted, and it has to stay on our network. So, I think blending a couple of the conversations we've had here already, using your phone or even the company phone standard text messaging to talk about patient information from a policy standpoint is not allowed. From a practical standpoint, that it happens. There was another article I was reading the other day that said, 50% of people ignore company policy or don't know it. So, and I think that's probably a low estimate. So we do look at these things, what you were just saying around, there's a policy angle of things and a technology angle of things. And there are some things out there that we're looking at to try to allow that more secure communications. And then in addition, part of the mobile infrastructure that we've built, more for the customer facing, but it does allow, there's a secure email in that for patients to actually email their doctor and the doctor to respond, things like that. So we're looking towards more of that, either in-house built or acquiring technologies that allow that secure encrypted communication to make sure that the data is safe.
For us, a lot of that internal communication happens in the EMR. We use one single EMR for 11 physician practices, and they have a messaging capability in there. But that only covers about 75–80% of that referral communication that needs to happen. And I'm sure, as we've said, it's happening outside of our control in some instances. We're also looking at, because Maine has a very good health information exchange that's very mature at this point, and they're getting ready to roll out some direct messaging in that. And I would really like to push our providers to using that and help encourage that adoption, because it would also encourage further adoption of the HIE.
And similarly, we also, by policy, prohibit the distribution of PHI through email communication. We do encrypt when there is PHI distributed, and we have some features that detect PHI if the user has accidentally not encrypted it. So that actually produces some very interesting results when people send emails and don't really think of something that they're sending actually is PHI, and it gets picked up in our filter. So there's been some interesting conversations from that, but thus far that seems to have served us well.
Yes.
I have two questions. The first one is, the mobile devices, including laptops, are provided to access information and interact with the hospital systems. But unfortunately, sometimes it may so happen that the user may store PHI on the laptop or any other device. It complicates if it is BYOD because it goes beyond your network and it is outside the system. And the greater risk is having the PHI in the device. Have you done anything to discover or routinely check any PHIs in the mobile devices and make policies, procedures, implement, enforce, sanction, anything like that?
Well, in our case, when people use BYOD on their personal device, because they're accessing their virtual desktop environment, there's never a point at which the PHI is actually physically on the device. It's always in the virtual environment. So there would be no way for them to get the PHI onto the physical device.
and pretty much similar in my organization, because they have to go through the guest network and emulate either their desktop or run the apps. We don't allow the local device control, so they're not going to download to a thumb drive or anything else.
And from our perspective, since we don't have the virtualization in place today, that's one of the major reasons we don't allow personal devices.
So that raises a follow-up question. How do you know that they don't have PHI in their mobile devices? Have you any time randomly checked?
On their KP-owned devices, or
Anything, either the mobile devices
so
provided by the
on
hospital?
on the devices we provide, we do check. Yes, we do have endpoint solutions that have searched it. Actually, we just completed a full inventory and found 9 petabytes of information. So that we do have scans and things like that do check on a regular basis.
My second question is, there is a increasing use of NHIN Direct for clinical messaging. A lot of physicians and a lot of practices are using NHIN Direct for messaging between the providers. These NHIN Direct uses actually an SMTP protocol, which is email exchange in fact, and you can configure on your iPhone an email for an indirect messages. So which means the iPhone now has a lot of clinical messages which is coming through these an indirect messages. So how do you see that as a risk? Is an indirect is a good thing to use, or is it a risk, and how to prevent those risks, how to mitigate them?
I think we kind of touched on that a little bit earlier. The technology is developing to address that. I definitely see it as a risk. We know that it's happening, but at the current point, we don't have anything installed to actually as an alternative. I think you talked a little bit about using your EMR to do that. We don't.
Yeah, I think as far as direct is going to be concerned, hopefully it'll stay within the web-based portals and not actually go to Exchange or other email.
Yes.
The further convergence of the personal device, the mobile device, the tablet, the smartphone, with the actual business, with patient-centered medical home, tighter integration with PHR. You want your patients to be, collect more information about their vital signs. I heard Apple is going to release earbuds, that take vital signs as much as it can through the earphones, things like that. There's a patent underway for that. How do you plan for the controls, right, to cut off the personal use, right? Do you have a strategy in place to not dial it back too much? Because at the same time, you're going to have to embrace the next wave, which is get the efficiencies in the PCP community, right? Enable patient-centered medical homes. Get the care teams out there, all right? The post-acute care, home health. Really unleash that technology potential. What's going on from a roadmap perspective, in your opinion?
I think at a high level, strategically, we need to embrace that and not put up barriers to it when it comes along, for all those reasons. I mean, we're now becoming self-insured in the hospital with our own employees. We need to encourage that within our own staff as well. So,
From our perspective, actually, we currently don't allow personal devices for our employees, but we are actively, trying to push to our customers more and more mobile solutions. And so I don't think our non-personal device strategy is going to be all that long term, quite honestly. I think we're looking very actively at all the controls that we feel we need to have in place before we go there. We just didn't have them yet, so the policy we wrote is, not now, basically. But it's interesting you mentioned that, because George Halverson, who's our CEO, has just been kind of shopping around his 4 sites of care strategy that we're going down. And as a security organization, we're participating heavily in, which really is, that the standard sites, right, in the office, in the hospital, but then adding to that home and mobile. And so we've taken our first few steps into mobile, but we are looking pretty actively at how we can actually start to do things like televisits, and all. Actually, we have a number of pretty active pilots in that space already.
And that's where, you know, we're, as Continuum, are driving some of that activity as well. So I think that's one of the things that we're going to see in the future is more of that initiated activity from the consumer. Some of that's going to be driven by the clinical practice and saying, you know, as we move to more of the ACO world, as we move more into the capitated care environments that, you know, we're starting to see roll out, and patient-centered medical homes, where you're going to end up with device architectures that are going to be given to the consumer as part of the clinical care, going to be given as part of the overall follow-up process. And perhaps then what you start to see is, as the gentleman mentioned, individuals bringing back into the system a desire to connect to clinical information that they've been collecting from a personal health perspective. That's sort of the second phase, as I mentioned earlier. And you started talking a little bit about that, Jason, as well, and that how do you see that sort of information rolling out? Do you have plans for that currently? We've heard a little bit about what Kaiser's doing, but do you have plans for that to really focus on how we're going to integrate that second set of data that's not derived from our employees, but from our customers, if you will?
We're looking at it very heavily. It's kind of a trust issue, right? How accurate is it, you know, and how much can you really rely on it? So we're piloting a lot of things right now. The doctors are looking very closely at how valuable it is to them and what they can do. You know, to some extent, it's pretty pervasive already. If you look at things like remote monitoring for pacemakers, et cetera, it's out there. It's just a matter of figuring out how we incorporate that in and trust it.
I think it's something we're going to have to build on to get there. You know, we look at our population of patients being primarily Medicare and Medicaid. You know, be careful not to stereotype those populations, but they're not always the first ones to embrace that technology or to really address their own personal health needs. So we're going to be actually starting with the portals and trying to get them to adopt there and then move it forward. At the same time, though, we are working on telemedicine applications with home health agencies that could do that monitoring of those patients that are in homes, because it's going to work towards our value-based purchasing to try to reduce the readmission rates, especially on some high-risk patients.
You know, and I agree too that my sense is that a lot of that data is already out there, and not to fall back on kind of a common industry cliche, but to me it's really a matter of converting that data into information, and how it is that you do that. I agree that I think it's really part of an overall access strategy, whether it be through physician portals, patient portals, HIEs. Interestingly, in contrast to the state of Maine, California is behind in the HIE space, and in our infinite wisdom, we've decided that our state needs about 10 HIEs just to kind of mix things up a little bit. So we're still working through that piece. So I think it really shows that different places are in, or different organizations are in different places, not always completely because of themselves, but also because of the external factors. And for us, I think that in particular, as the HIE conversation and direction continues to crystallize, I think that'll have a big part in pulling in that data and making it meaningful information that we in turn can then use.
Okay. Question here?
Yes, the three of you seem to be in the forefront on mobile device thinking, but when you look at the data breach statistics, the predominant source of breaches is on mobile devices. So have you seen in the industry any publications or best practice documentation that you might refer us to that sort of crystallizes all of these, your thinking?
Yeah, there's actually quite a bit out there. One place I would suggest starting is actually go to the HIMSS Privacy and Security tab. There's actually was a mobile security work group, and there's a toolkit there that has a lot of links to other sources that can help you pull in and look at the best practices, where to start, how to do the risk assessment, those types of activities.
And as mentioned in the last session as well, NIST has a wide range of tools as well that, while not all based in healthcare, do cover quite a bit of the policy aspects of mobile device management as well. Back in the back over here.
With tight budgets, I'm listening, it sounds great. So how do you justify it? Business, economics? Is it a pilot? Are you in production? How do you, right now, not in the future when we're doing the remote monitoring, I can see that ROI. But today, does that make sense? Does the question make sense?
Which specific part are you
Well,
justifying?
we've now got MDM out there, and so docs are coming in, and we've got the VDI is set up, and so you have the infrastructure investment I think you were making, and all these are great, but how are we justifying it? Somebody's signing a check.
Right.
They said, why? Yes.
Yeah. And that's kind of where we're at, honestly, is looking at, especially being a large organization, the costs for us are quite high. You know, there's certainly a productivity angle to it that is where at least, you know, we're looking at it internally, that's where they're coming from. It's, you know, I'm visiting patients all day long, and I've got an extra 2 minutes while I'm standing in line waiting for the lunch, and if I could get through 5, 6 emails, that to me is something I don't have to do when I get home at night. So there's that aspect to it. As we start to get more into the actual clinical applications and things like that, I think it becomes a little bit better of an ROI where you can show improved work streams and hopefully more accurate data if it's being taken right on the spot.
Your question is a great one because it dominates how we develop our strategy. And primarily what we do is we look at it from a common sense point of view and what can we re-leverage. I mean, you've heard me talk about utilizing our remote access portal. And so we leverage that on our guest network as we already had that investment. It was something we had to do for our providers to support other needs in the organization. And we leverage that from a security point of view and put it on the guest network, which was something else we had to do. So, you know, if we can repurpose as much of the work we do as possible, it helps us, you know, maintain that security without making those big investments.
You know, I agree. I think a couple of the important features are, one, the enhanced productivity. That definitely makes a difference. And over time, conceivably, it's possible that the number of physical devices that you have to purchase will decrease as well. And with that comes all the added costs onto devices that you don't necessarily think about. So the operating system licenses, the antivirus, all that. If you're not purchasing the device, you're able to move away from that cost. And I won't get too much into the technical weeds, but on the back end as well, from the server perspective, when you are running virtual servers versus physical servers, there's a lot of savings there as well, both in terms of the decreased number of physical servers, but also the ability to rapidly provision and you know, move from one server to another without having to fill you know, a data center. In our case, it's been a huge savings for us because we're about 85% virtualized. And a few years ago, we were at a point where we were running out of space in our data center, and we were looking at major construction projects. Are we going to build another data center? How are we going to handle this? Well, by virtualizing, we've been able to stay in our same data center space over those past several years, and we have not had to build out and been able to stay within that space. So for us, that's been a huge savings.
One of the things that's also we're starting to see as a trend in the industry, and that is the advent of custom app stores. Is this an area where you have some interest? You know, there's organizations such as Haptique, which are now developing for hospitals a special version of an app store that allows, and you know, in essence, a safe environment for those that are downloadable apps. Is this considerations that you're looking into as well?
Yeah, it definitely is for us. As we look at internally clinical applications, things like that, we don't want that to go through the public app stores.
Yeah, and I would say it's not on our horizon right now, again, for a lot of the reasons I've stated earlier.
And for us, it's not on our immediate horizon either, particularly because of the investment that we've made in the BYOD piece. That
devices, you know, provided by the organization. But at the same time, the mobile devices or your own devices will also bring the extra kind of, you know, risks, you know, into your environment. How do you guys, you know, work in the area to persuade your senior management board members to present kind of, you know, the very substantial benefits that, you know, the real benefits will offset the risks, the extra risks you have to manage?
For us, the adoption piece was very important, and we were fortunate in that our medical staff really provided leadership in this development. They were really clamoring for this, and they were, and I would encourage people, as you're thinking about developing a BYOD policy, to really engage the medical staff. Our CMIO was just an absolute champion for us, and he really engaged the medical staff to build that level of support where when we were piloting this, and this is a great story from an IT perspective, we had a waiting list of people who wanted to be part of the pilot from the medical staff. So getting that initial buy-in and having someone other than the CIO and the IT team saying, hey, you know, this is a good thing, because you know, we're saying that about 100 things, and oh, you know, here comes Kirk again, you know, saying this is a good thing and I need $1 million for it. When you're able to leverage your medical staff, or really, you know, no matter what the analog is, if you're doing something for your respective departments, when you have your end users who are active proponents for it, it makes a huge difference. And in our case, I always say, you know, major kudos to our CMIO and our medical staff for helping us move this from the conceptual stage to the pilot stage and to where we are today, live in production.
A little bit different in my environment, but adoption is key. And one of the things where our two primary vendors for EMR applications in the hospital, neither one of them support a Macintosh platform. And so this bring your own device is actually, in the way we've approached it, actually allows those die-hard Macintosh users or Apple users to bring in their iMacs and their Mac laptops and connect to our guest network and still adopt to the technology. We have a very high voluntary CPOE utilization. We've eliminated transcription in our practices because they're all using the EMR extensively. So it's had payoffs for the hospital to take this approach.
Yeah, and for us, I think it's similar to, is it Kirk? Sorry. We just met before this. So for us, it's kind of similar, though, where the physicians they're knocking at the door or beating it down, probably be a more accurate way to put it. So in terms of adoption and things like that, we've got a lot of very technologically savvy users that are really clamoring for it. What we did with them is we sat down and we did that risk assessment and we looked at the various use cases and we said, okay, here's the risks in each area, and that at least got them to the table to say, not only do we want it, but we want to do it the right way, and which is why we don't allow BYOD right now, because we've all agreed we need to put these things in place. So now we've got both business side and IT side working together saying, we want to do this, we know we need to do these things, so the funding and all of that for those projects is going pretty smoothly.
Yes, thank you. The idea of portals has come up a couple of times in giving access to mobile devices over browsers, and I'd be curious to hear about securing the authentication point for different communities, physicians, other consultants or people who are part of the medical community, and the patients and the members in terms of coming in a multi-factor authentication and having, I'd be interested to hear about the trends that you're seeing or the approaches that you're taking for securing it from a browser-based, so you're not doing an either container-based or an app-based approach. And then kind of a follow-up about, you know, some of the, if you're hearing or seeing anything about, you know, some of the device makers starting to think about biometric applications on their smartphones for using, for doing that to actually authenticate? Thank you.
Good question. So from our perspective, we only have the mobile apps and the optimized website for external, meaning customers logging in to view their information. And there is, when you create an account on kp.org, we actually do a pretty good, we use RSA to do an external identity proofing, making sure you are who you say you are, et cetera. It is still username, password. We haven't gone to multi-factor authentication, but we are looking at that quite closely. Regarding biometrics on the phones, I haven't seen anything specific yet, but I think it's whether it's text message to the phone, whatever, some kind of secondary factor that isn't carrying a token around is definitely something we're looking for.
Yeah, I would say, again, balancing costs. We use an RSA method for our portals, for our providers and our workforce. We don't go, we still have SSL secured for patient portal. We're just dipping our toes in that water. But more of that onus is on the patient to take that. So we have some shared risk with the patient in that environment. It's a little bit different than with the workforce. But I'm watching heavily with biometrics because I'm not going to be able to afford a token-based type system or some of that two-factor authentication. So I think biometrics is probably going to be as it's advanced over what I've seen over the last decade, that's probably going to be a better way for us to go.
I guess we don't really have that concern. We don't have the virtualization, but we do monitor for where the network connections are coming. We don't block actively. There are,
One of the things that
especially if somebody connected in California and 2 minutes later,
so tied to the mobile wallet, identity management, and using the same chips that are some cases. So, for example,
I'm interested in each of your thoughts on reasons why you implemented a BYOD policy. Are there times when you wonder if this would be so much easier if I did not have this policy, or conversely, you have a no access policy for BYOD, this would be much easier. Also,
that we're happy, you don't want to go down. You really want to, at least in our case, you want to focus on supporting the connectivity so that they can access hospital resources and not get into the business of supporting every device under the sun. But for the most part, feedback has been really excellent, and our experience has been really positive with what we've done.
and I'll just say that, I think it's impossible not to have one at this point, just because the users, especially the doctors, et cetera, that are pretty intelligent, savvy people, they're going to do it. So we got a lot of questions around what is our policy and what can we do, what can't we do. And initially, we quickly put together kind of a facts and pointed them to safe data and practice.
Policy-wise, we address that as, getting a device is not an expectation of working more than your allotted hours, et cetera. It's, the legalese part of it is covered. The wellness conversations do happen, but that's at a much broader context. KP's actually quite good about work-life balance and things like that, and having those conversations and encouraging people to have their time to recharge and move forward. So, yeah, you need at least a half hour, right? So.
The only thing I'd add to the comment is we did specifically address the policy around exempt versus non-exempt employees, because I've been at a prior organization, we've been sued by, making email available and having somebody, when they were terminated, then present us with a time card of hundreds of hours of time they spent on email, and when it got brought to the labor board in Maine, we had to pay that person for those hours, even though we weren't requiring them to work to do their emails. So we've been very clear that we do not give access to hourly employees.
Yes, similarly, the exact same consideration for us from a policy perspective. That's part of why, we too did, even though someone who is non-exempt could conceivably bring their own device, they're not permitted per policy for that very reason.
We heard a question from the last questioner about about location-based activities and location services. Many of you are using a strategy that actually uses a virtualization technology, and obviously there's some sort of you manage that. So there's inside the hospital, there's a guest network that's in part of the hospital, then there's the external network. Are you doing any sort of limitations based upon location-based access to the network itself? Do you limit, for example, access outside the country so that you're eliminating some of those risk factors?
No, but you give me some things to think about.
Yeah, that really hasn't been a consideration for us either. People being outside the country, we really, kind of our catchment area is really the Central Valley of California, so we don't really have that concern either.
We don't have the virtualization, but we do, so we do monitor for where the network connections are coming. We don't block actively, but if there are, especially if somebody connected in California and then 2 minutes later connected from China, we'll follow up on that.
Sorry, thanks. Yes. Last
Yes.
question.
Okay. I'm interested in each of your thoughts on reasons why, for example, you implemented a BYOD policy. Are there times when you wonder if this would be so much easier if I did not have this policy, or conversely, you have a no access policy for BYOD, this would be much easier? Also, in that same sense, what are the pressures? What sort of pressures are you getting from various parties to reverse that policy, whichever way you went?
You heard Mike, when he introduced the program today, talk about the final exam analogy. It's similar. I'll wake up in the middle of the night and really question, why did we have this? I just have these nightmares about what could come out of it. But then we come back to work and think about, the reasons we made that, tough balance and why we adopted the policy we did, and knowing the risks involved with it. So I don't think there's a black and white answer to that, but no, it's a constant struggle, internal to my IT organization and internally for me.
Probably a similar answer from me. I guess the example I mentioned earlier, when a user or two brought in a desktop iMac and started accessing BYOD, I admittedly started thinking, okay, what's next? In particular, when the request comes, hey, I have my iMac here, can you now take away my hospital-issued PC? The answer was and will continue to be no, because that's your primary device. Other than that, no real concerns. I think inevitably what you do see is people will have questions about the device that they bring. So how do I find my family pictures? This movie I downloaded, I for some reason can't play. And those are, as I said before, questions or a path that you don't want to go down. You really want to, at least in our case, you want to focus on supporting the connectivity so that they can access hospital resources and not get into the business of supporting every device under the sun. But for the most part, the feedback has been really, really excellent, and our experience has been really positive with what we've done.
Yeah, and I'll just say from that, I think it's impossible not to have one at this point, just because the users, especially the doctors, et cetera, that are pretty intelligent, savvy people, they're going to do it no matter what. So we got a lot of questions around what is our policy, and what can we do, what can't we do, and initially we quickly put together kind of a fax and pointed them to safe data handling practices and things like that, but we knew we had to actually have a specific policy around mobile devices and BYOD.
All right. Well, that's the end of the hour. Kirk, Ralph, Jason, and Chuck, thanks so much for all that information. Everybody, thank you.
Information, and there is, when you create an account on kp.org, we actually do a pretty good, we use RSA to do an external identity proofing, making sure you are who you say you are, et cetera. It is still username, password. We haven't gone to multi-factor authentication, but we are looking at that quite closely. Regarding biometrics on the phones, I haven't seen anything specific yet, but I think it's whether it's text message to the phone, whatever, some kind of secondary factor that isn't carrying a token around is definitely something we're looking for.
Yeah, I would say, again, balancing costs. We use an RSA method for our portals, for our providers and our workforce. We still have SSL secured for patient portal. We're just dipping our toes in that water. But more of that onus is on the patient to take that. So we have some shared risk with the patient in that environment. It's a little bit different than with the workforce. But I'm watching heavily with biometrics because I'm not going to be able to afford a token-based type system or some of that two-factor authentication. So I think biometrics is probably going to be as it's advanced over what I've seen over the last decade, that's probably going to be a better way for us to go.
Yeah, I agree, particularly in the biometric space. I think there's a lot of opportunity there, and I think in the coming years there's probably going to be a lot of progress there.
You know, one of the things that we're seeing on an international scale too here is that we're seeing NFC being used as a new way to identify individuals. So tied to the mobile wallet identity management and using the same chips that are built in some cases the Android phone. So for example, there was when we rolled out, there's some technology that was rolled out right after post-tsunami in Japan, where they had to do some identity management in the camps to be able to collect data from these individuals. They were using basically like a little small NFC. If they gave them an NFC card, or they used their phones that had NFC chips in them. So they were using that as their identification technology. So yes, go ahead.
More on the policies and procedures, have there been discussions as you advance the ease of use with mobile devices for use in work? What kind of conversations are you having internally to balance employee wellness? At that point, they're always on. Now they have plenty of excuses to work at home. They have plenty of excuses to work in the car. You're getting more out of your exempt employees. Do the hourly people now feel pressured to be always on? Do they need to be compensated now more because they work more? What's the internal dialogue in your organizations because of the ease of access?
That's a really good question. I'm glad you brought that up. There has been some cases where folks have actually sued the organization because they feel like once they had these mobile devices, they were really being asked to work off hours and things like that. So, policy-wise, we address that as, getting a device is not an expectation of working more than your allotted hours, et cetera. It's, the legalese part of it is covered. The wellness conversations do happen, but that's at a much broader context. KP's actually quite good about work-life balance and things like that, and having those conversations and encouraging people to have their time to recharge and move forward. So, yeah, you need at least a half hour, right? So.
The only thing I'd add to the comment is we did specifically address the policy around exempt versus non-exempt employees, because I've been at a prior organization, we've been sued by, making email available and having somebody, when they were terminated, then present us with a time card of hundreds of hours of time they spent on email, and when it got brought to the labor board in Maine, we had to pay that person for those hours, even though we weren't requiring them to work to do their email. So we've been very clear that we do not give access to hourly employees.
Yes, similarly, the exact same consideration for us from a policy perspective. That's part of why, we too did, even though someone who is non-exempt could conceivably bring their own device, they're not permitted per policy for that very reason.
We heard a question from the last questioner about about location-based activities and location services. Many of you are using a strategy that actually uses a virtualization technology, and obviously there's some sort of you manage that. So there's inside the hospital, there's a guest network that's in part of the hospital, then there's the external network. Are you doing any sort of limitations based upon location-based access to the network itself? Do you limit, for example, access outside the country so that you're eliminating some of those risk factors?
No, but you give me some things to think about.
Yeah, that really hasn't been a consideration for us either. People being outside the country, we really, kind of our catchment area is really the Central Valley of California, so we don't really have that concern either.
We don't have the virtualization, but we do, so we do monitor for where the network connections are coming. We don't block actively, but if there are, especially if somebody connected in California, and then 2 minutes later connected from China. We'll follow up on that.
Sorry, thanks. Yes. Last question.
Okay. I'm interested in each of your thoughts on reasons why, for example, you implemented a BYOD policy. Are there times when you wonder if this would be so much easier if I did not have this policy, or conversely, you have a no access policy for BYOD, this would be much easier? Also, in that same sense, what are the pressures? What sort of pressures are you getting from various parties to reverse that policy, whichever way you went?
You heard Mike, when he introduced the program today, talk about the final exam analogy. It's similar. I'll wake up in the middle of the night and really question, why did we have this? I just have these nightmares about what could come out of it. But then we come back to work and think about, the reasons we made that, tough balance and why we adopted the policy we did, and knowing the risks involved with it. So I don't think there's a black and white answer to that, but no, it's a constant struggle, internal to my IT organization and internally for me.
Probably a similar answer from me. I guess the example I mentioned earlier, when a user or two brought in a desktop iMac and started accessing BYOD, I admittedly started thinking, okay, what's next? In particular, when the request comes, hey, I have my iMac here, can you now take away my hospital-issued PC? The answer was and will continue to be no, because that's your primary device. Other than that, no real concerns. I think inevitably what you do see is people will have questions about the device that they bring. So how do I find my family pictures? This movie I downloaded, I for some reason can't play. And those are, as I said before, questions or a path that you don't want to go down. You really want to, at least in our case, you want to focus on supporting the connectivity so that they can access hospital resources and not get into the business of supporting every device under the sun. But for the most part, the feedback has been really, really excellent, and our experience has been really positive with what we've done.
Yeah, and I'll just say from that, I think it's impossible not to have one at this point, just because the users, especially the doctors, et cetera, that are pretty intelligent, savvy people, they're going to do it no matter what. So we got a lot of questions around what is our policy, and what can we do, what can't we do, and initially we quickly put together kind of a fax and pointed them to safe data handling practices and things like that. But we knew we had to actually have a specific policy around mobile devices and BYOD.
All right. Well, that's the end of the hour. Kirk, Ralph, Jason, and Chuck, thanks so much for all that information. Everybody, thank you.